for hypertension, Professor Iliescu and his group, please.
Thank you very much for the introduction. Huh? Okay. Well, it's a pleasure to be here. Thank you for the opportunity to, share some of our research that took part here at the university in Iași and also at the University of Mississippi Medical Center. So I'm going to show you some data related to the treatment of hypertension. Boring. We have a lot of treatments, pharmacological treatments for hypertension, yet most of the people in the world are sick and die because of hypertension. So I have a problem. What is that problem? Well, despite having a lot of medication that's available to us, and you all know it, although maybe you don't focus on cardiovascular disease, we're going back to the basics. The very first treatments for hypertension were surgical, targeting the sympathetic nervous system. After that, ACE inhibitors, ARB, and a plethora of medications came about. However, there's still a relatively large population of individuals that, despite receiving optimal doses of at least 3 different classes of antihypertensive medication, still have blood pressures of above 180 millimeters mercury over 140, which is called resistant hypertension. So, is the sympathetic nervous system important in hypertensive people? Some relatively recent studies in the past decade have shown, with a very nice and precise technique of measuring sympathetic activity, to the kidneys, to the muscle, or to the heart, or to the whole body, where they measure the discharge of norepinephrine specifically to each of these organs, showed that in hypertensive individuals, whether they're normal weight or obese, there is generally an increase in sympathetic nervous system activity to their organs. More than that, in people with essential hypertension, which is, as you well know, just a name describing our inability to identify the cause of hypertension, renal sympathetic nervous system activity is increased. And that's even more important in people with resistant hypertension that our pills cannot treat. Just a very brief reminder. How does the sympathetic nervous system affect blood pressure? Well, we all know. It increases heart rate, heart contractility, constricts vessels. And that's a very expedient way of understanding things based on the Ohm law that signifies an increase in blood pressure. But we all, with some exceptions, tend to forget the essential role of the kidney in regulating blood volume, which is actually the major long-term determinant of the sympathetic nervous system activity in determining blood pressure. How does the sympathetic nervous system change the renal excretory capacity? By 3 mechanisms. I'm not going to go into the details. This is too much physiology for most of the people present, probably. So by increasing renin and activating the renin-angiotensin-aldosterone system, by directly stimulating proximal tubular reabsorption of sodium and thereby water, by changing the activity of the sodium-hydrogen exchanger, etc. That decreasing the capacity of the kidney to put out sodium and water will actually lead to a chronic, long-term increase in blood pressure. So it's only natural, then, based on this data, that the sympathetic nervous system affects blood pressure, works on the kidney to affect blood pressure, and sympathetic nervous system activity is high in hypertensive people, Okay, let's cut it. Sympatholysis. We have beta blockers. Yeah, but they don't work very well. How about destroying the nerves, the sympathetic nerves? That has an advantage. You do surgery once, or implant a device once, and you're done. You don't have to take any more pills. That's what the advances in technology have provided. And we have two options. Renal denervation, cut the nerves to the kidneys. Until the 80s, we didn't even think that the renal nerves played any role in general in anything. They were just there. Yeah? Now we know that they only contain sympathetic fibers. So if we cut them, then maybe we can lower blood pressure. And we have devices that are inserted very easily through the Seldinger technique, and they zip through radiofrequency or alcohol injection, micro injections of alcohol, or actually freezing, and destroy the nerves around the renal artery to actually interrupt the sympathetic nervous system activity to the kidney. These are the results of the pivotal trial of those devices in people with resistant hypertension. What these results show you is that in people with innervation, there was a significant 14 millimeters of mercury decrease in blood pressure. But unfortunately, those that had the catheter inserted, but the renal nerves weren't destroyed, there was also a decrease in blood pressure. And based on our initial discussion, yeah, you know, data sometimes have a tendency to work against you. So why does this happen? A lot of explanations. Well, maybe the renal denervation wasn't very efficient. Here you have the results of the efficacy of denervating nerves in a group of people. And you see how the efficacy of the procedure varies greatly. Here you have experiments that were done in Mississippi in dogs. It's a very good, very accessible model for testing human devices. And you see that when we use the fancy catheter-based technique, we obtain only a 50% reduction, almost 50% reduction in renal sympathetic nerve activity, whereas if you do it surgically, abdomen open, and you visually cut and destroy the nerves, then you get 100% reduction. There's at least, this is a little bit old, there's at least 7 trials of different catheter-based techniques that show that have an indication that renal denervation may work for the treatment of high blood pressure. But all these studies show that some people respond very well. And I'm looking at Professor Duda because this kind of data actually reproduces what happens in immunotherapy in cancer people. It works brilliantly in some, but in some it doesn't at all. And we have no way of knowing who is going to respond. And this is what I'm going to show you, some basic experimental data where we try to identify markers or to find the reason why some patients will respond to renal denervation by decreasing blood pressure and why some wouldn't. If we induce high blood pressure by administering aldosterone chronically in dogs, you see they're hypertensive. That's mean arterial pressure of around 135. We denervate their kidneys, their blood pressure goes down for a couple of days. These are daily results. Blood pressure measured continuously, directly with the catheter inserted in the artery. So a very high confidence in the quality of the blood pressure measurement. And you see how the blood pressure returns to almost normal afterwards. So in this case, renal denervation doesn't work. Heart rate actually increases. Why is that? That's because when you infuse aldosterone and increase blood pressure because of let's say, a model of hyperactivation of the renin-angiotensin system, the sympathetic nervous system is actually suppressed. So if it's suppressed, denervating the nerves doesn't work. This is another experiment in which we induce hypertension, that's in rats, and this is done here at our university. where we could measure blood pressure chronically by telemetry for at least 90 days in this rats, so we can follow them longitudinally, just like we would do ideally in patients. And we induce hypertension by removing 80% of the renal mass surgically, one kidney, and the poles of the remnant kidney, and gave a high sodium diet. That mimics patients with CKD, chronic kidney disease, that have lost a significant number of nephrons. And basically, this is a volume loading hypertension. So you see how after the nephrectomy, you give them high salt, blood pressure goes up significantly by 15 millimeters of mercury. Here we denervated them. Brilliant response. Blood pressure went right back to normal. And just between parentheses, this, I'd like to make this point. This is why it's important to actually do experiments, at least in the cardiovascular field, long term, to see what happens beyond the acute phase. Because if we stop the experiment here, 3 days after denervation, blood pressure low, we're happy. But look what happens over the course of 2 weeks. Blood pressure creeps up back to exactly where it started. And we said, okay, well, we only destroyed the renal nerves. How about having sympathoinhibition globally? So we'll clone it in. That acts in the brain to actually suppress sympathetic nervous system throughout the body. Surprise, what actually happened? Blood pressure went a little bit higher, although not significantly. In any case, it didn't go down. So why doesn't the sympatholytic therapy doesn't work in this model? Well, here you have a daily measurement. I won't go into the technical details. Suffice it to say that we have a mathematical approach to actually analyze the variations in blood pressure that are synchronous with sympathetic vascular activity. And from that, we can infer the sympathetic outflow to the vessels. So if you look at these 2 points, you see that they are significantly lower than during the control. So when hypertension is induced, that's in the context of high blood pressure, sympathetic activity is actually reduced. Look what happens with global sympathetic activity when we denervate the kidney. That's because blood pressure went down in the first 2 days and sympathetic activity went way up. And with the normalization of blood pressure, sympathetic activity went back to normal. Clonidine did exactly what it was supposed to do, lower sympathetic activity, but it didn't lower blood pressure. Basically, based on this data, and I won't go into the details of this. This is a table that we put together in a paper dealing with the markers of sympathetic activity and efficacy prediction for renal denervation. We can say that only when hypertension is dependent on a heightened sympathetic activity does renal denervation work. But we have yet another way of reducing sympathetic activity. We use a pacemaker. We put it at the bifurcation of the carotid, where the carotid sinuses and the afferents of the baroreflex system, of the baroreflex system go to the brain, and when the blood pressure goes up and it's detected as being up, the brain stem actually lowers sympathetic activity and increases parasympathetic activity. And we have devices that actually stimulate those nerves to trick the brain into sensing the high blood pressure. And it's called electrical baroreflex activation. These are the results of the pivotal trial investigating the efficacy of that device in treating resistant hypertension individual. 6 months worked fantastic. However, follow up at 12 months, blood pressure went right back to normal. Well, I mean, you know, you can imagine that at the point where you go to clinical trials, phase 2 clinical trials, a couple of $1 billion have already been invested into the development of those devices. But more important than that, the question is, well, why do these trials fail? The physiology is there, the concept is there, there's something wrong with it. So we try to answer the question, how does, or why doesn't the baroreflex activation lower blood pressure in all individuals? Here we have experiments in dogs that really were the most really surprising thing that we've ever seen. We know that the sympathetic nervous system acts to regulate blood pressure through the sympathetic nerves. Well, what happens if we denervate the kidneys and activate the baroreflex? The blood pressure goes down by exactly the same level. So apparently we're contradicting what we believed in, and it's written in textbooks. Arthur Guyton, maybe to more recent students, says something to you. I mean, that's basic knowledge. Why does that happen? It happens also in patients. Patients where renal denervation failed actually have a response when baroreflex activation is implanted. How about aldosterone hypertension, where renal denervation, I just showed you, didn't work? Well, it does in this case. Baroreflex activation does lower blood pressure. Of course, the difference is that baroreflex activation lowers sympathetic activity throughout the body, whereas the renal denervation only to the kidneys. And look what baroreflex activation does to the sympathetic activity measured by plasma norepinephrine concentration. It's lower during control. When you administer aldosterone, sympathetic activity gets below control, but the baroreflex activation is so efficient that it lowers much below the new lower level the sympathetic activity, which translates into a high efficacy of blood pressure reduction. The same experiment in volume overload, high salt, CKD model. As opposed to renal denervation, baroreflex activation actually does lower blood pressure, and it does so by lowering even further than the reduction that happens with the sympathetic nervous system activity. Here you have the results of a strange experiment that we thought about. The baroreflex detects blood pressure decreases. Is this effect opposing our classical antihypertensive therapy? Here we have experiments in dogs, normal blood pressure, that were administered calcium channel blocker, amlodipine, for 3 weeks. You see how the blood pressure gets lower by about 10 millimeters mercury with chronic calcium channel blocker treatment. The baroreflex activation actually manages to lower blood pressure that was already lowered by calcium channel blockers. So that begs the question, does amlodipine actually stimulate sympathetic nervous system to counterbalance the effect of the calcium channel blocker? We don't know how the baroreflex activation is capable of lowering blood pressure in the context of an already low sympathetic activity, and especially in the absence of the renal nerves. For the sake of time, I won't go into the details of all these graphs, but this is a mathematical model. It's an in silico model. It's not based on artificial intelligence. It's based on human intelligence that was initiated by Arthur Guyton in the 50s. He was probably the first doctor using a computer in the United States to understand how blood pressure is regulated. So he devised a computer program modeling the organs that are involved and their activity that are involved in blood pressure regulation. Today, his model that initially had 180 parameters, now it has about 5,000 parameters and variables, ordinary differential equations describing the functioning at an integrated level, not at a cellular level, but organ level of all the organs in the body. It's a human physiology model that actually breathes, has blood pressure, heart rate, can be a man or a woman, etc. So we use this model to try to understand or to devise experiments to explain how bareflex activation lowers blood pressure even when the renal nerves are actually cut. And I'll go straight to this slide. So basically, what we did was to model the control, the normal situation, a situation where the effects of bareflex activation are fixed to the kidneys, a model where the cardiac effects of bareflex activation are fixed to the heart, and a model where we didn't let the sympathetic nervous system do anything neither to the heart or to the kidneys. You see how this mimics basically the effect of aldosterone and all those situations where renal denervation didn't work. So what we eventually found using this was that the only factor that predicted a lowering of blood pressure by bareflex activation in the absence of the renal nerves was a very marked increase in AMP. AMP, atrial natriuretic peptide, is as the name says, a natriuretic factor that is released by distended atria in the presence of accumulating fluid volume. You see how that increase is extremely marked, and this is actually what explains the effect of sympatholytic device in lowering blood pressure even when the renal nerves are not present. So basically, finally, it is still the kidney that plays a major role in the regulation of blood pressure. So in terms of the future directions, they have good safety profiles, long-term adherence, because it's a one-time procedure. It's a mechanistically relevant approach, but the need to identify responder profiles is more important than ever, because there has to be a component of sympathetically mediated hypertension for these devices to work. And also, we have taken into the consideration the comorbidities that are related to the hypertension. Some of them, like obesity, hyperaldosteronism, or renal function, or renal dysfunction, if you want, which are associated with sympathetic activation. So with that, thank you very much for your attention, and questions whenever.
Thank you very much, Professor Iliescu. Well, I have a few questions, and maybe we can have a short discussion about this. And it's not really my area, but I think there's some similarities with the things that we're thinking about every day. So one of the things that I've been thinking about is, with VEGF inhibitors in oncology, you often see hypertension. And they've been very interested in finding biomarkers to figure out who might experience that. And there were certain SNPs, for example, that predicted that patients are maybe at risk of developing hypertension. Have you or has anybody looked at that, at some genetic variances that may explain the differences in response?
I don't know to tell you about the SNPs or genetic variances. What I can tell you is the physiologist's point of view. Whenever there's ischemia, and wherever that ischemia response does not result in an appropriate VEGF production to restore normal blood flow, like, for example, in preeclampsia, where we know very well the circulating antibodies against VEGF, or hypertension ensues. Whether that ischemia is actually in the leg, and we have models, because we thought it cannot be an isolated event only related to preeclampsia. Why that happens, we don't know, but the logic would be that whenever VEGF is not allowed, exactly like you showed yesterday, if I remember correctly, where VEGF is not allowed to restore normoxia, and actually through some mechanisms that we don't know yet, those vessels are not appropriate enough to actually restore a normal level of perfusion and oxygenation to the targeted tissue, then hypertension will ensue. I would rather see it more of a physiological problem than a genetic problem. Probably those patients that don't develop hypertension actually have an adequate response to VEGF.
And have you looked at soluble biomarkers for, so since you mentioned preeclampsia, there's been a lot of interest in soluble VEGF receptor 1, which actually blocks VEGF. Have you looked at that by any chance in the patients?
Yes, in patients, no.
Oh, okay.
Well, I mean, not personally. SFLT,
Yes.
the soluble
Yes,
VEGF
exactly.
receptor, is actually present in all ischemic patients, in preeclampsia patients. Basically, that's the work done, I can't remember the name right now, that basically established the circulating truncated SFLT form as the basis for the inhibited VEGF response in preeclampsia. But what's really important is that SFLT circulates even in patients with CKD, and may explain actually the hypertension that ensues.
The other thing that I've been thinking about is, there's a lot of interest in oncology in looking at ARBs beyond the effects on the vessels. There's certain effects on fibrosis, certain effects on tissue fibrosis, certain effects on inflammation. Do you think there's a component there that it might be different between this, pharmacological approach versus this implants on the effect of resistance?
In these studies?
Yes, because the pharmacological approach may reduce fibrosis, for example, or may reduce inflammation. There's some, at least in cancer, I don't know about hypertension, but I'm just thinking, is there some connection you can think of?
Most likely, yes. And actually, from a cardiovascular physiologist perspective, disconnecting blood pressure effects from antifibrotic, anti-hyperplastic effects of ARBs and all the other medication. It's really, I mean, there has been arguments for a non-pressure dependent effect of all these medications. I personally, based on the data that I've seen, don't believe in that. Simply because if you lower blood pressure, you're going to get those effects.
Okay.
And if you lower blood pressure by other means than ARBs or ACE inhibitors, or if you maintain the pressure by infusing phenylephrine, for example, continuously, those effects, although they are there, antifibrotic, so on and so forth, at the molecular level, and you can detect them, Western blot, PCR, whatever you want, they don't have a resounding effect in the whole body. I mean, in terms of long-term efficacy.
Okay. Any questions? Yes.
Congratulations for the presentation and for the concept, but I wonder, it is not my area with the kidney. We can imagine a similar model for portal hypertension. We struggle a lot with portal hypertension in liver cirrhosis, and we are doing tips and so on, but maybe a denervation, if could be possible, will be much easier.
My silence actually says, no, this is a fantastic question, really. Thank you for that. Didn't think of that. Yeah, it's something that really has to be, in a way. Right.
Main mechanism for progression of liver cirrhosis from compensated to decompensated state. If we can somehow to stop this kind of progression, will be wonderful.
I think this is a brilliant question. I'll just give you something right off the top of my head. We know as physiologists that the sympathetic nervous system, beyond their effects on the kidney, they have a phenomenally powerful effect on the veins rather than the arteries. So vena constriction is much more important in the acute effects of increasing blood pressure than arterial vasoconstriction. What I can tell you for sure is that none of the patient studies included people with portal hypertension. Obviously, that was obvious criteria for exclusion. But I can very quickly imagine a portal hypertension model, Okay, great, fantastic. So we have models, animal models of cirrhosis, tetrachloride, and renal denervation is something that we do. We actually also do barreflex activation in rats, which is a little bit more tricky because they're really... Well, that's exactly the point. If you obtain a central sympatholytic effect, then that will reflect also on the portal, venous circulation. And there's some data about afferent information from the kidneys that actually, when you cut the nerves, may lower sympathetic activity centrally. So that's what I'm thinking about. But yeah, brilliant idea, excellent idea. That's something that would, yeah.
Any other question? All right.
Thank you very much.
Thank you very much again. And congratulations. The next presentation is targeting inflammatory mediators in experimental severe asthma with acute lung injuries. It's a large team. I'm not sure who's going to present, but please. Yes.
I'm Cristina Ghiciuc, and I will present this.
Thank you.
This work is the result of PhD students' work. Three PhD students. They work this for their PhD thesis in collaboration with the immunology department, with the histology department, pharmacology department, and this experimental part was done in CEMEX because this is the place where we can do all the experiments in very good conditions. Of course, after having all approvals from ethics committees to have these experiments done. So why did we choose a model? We tried to choose a simple model starting from the frequency of acute respiratory distress syndrome. And there are two situations which increase the admission in clinic, mainly complicated asthma and acute pulmonary lung injury. And we tried to do a model starting from these 2 points, 2 diseases, severe asthma and acute lung injury, which have as a common point the acute respiratory syndrome. It's not working. Okay. And for these two, pneumonia is the trigger for both of them. And in the case of these two entities, I think this is not working. In case of these two entities, the high levels of interleukin the high levels of interleukin 17 are the K factor, which explains the oxidative stress disequilibrium. So we tried to see in literature what is happening at these levels, both levels, if it's an infection and if it's inflammation. And in both situations, the increase of interleukin-17 determined the accumulation of neutrophils and also destroyed the cell wall, the respiratory cell wall. So we starting with this, also we saw in literature that in asthma there is a phenotype which is with the high interleukin-17 and can be let's say a link. We suppose that it's a link between this high level of interleukin-17 and psoriasis. Both of them have this level of interleukin-17 and we can target with anti-interleukin antibodies. So we suppose that giving some substances which have as target this axis, we can have beneficial effects. And we choose anti-interleukin-17 antibody, but we tried also to choose other substances which can have effect on this axis. These were demonstrated experimentally by other authors, either on acute asthma in mice, in experimental animals, or in acute lung injury separately. And we choose some plant extracts, magnolol and honokiol, and metformin, which is a synthetic derivative, also from starting from plant. And the main objective was to demonstrate which are the effects at pulmonary levels on inflammation parameters. And we determine, first of all, which are the specific IgE, OVA IgE. We evaluated the cytokines in bulk supernatant, in tissue homogenate, and we also did histologic analysis to see if there are beneficial effects or not. And for this, we divided the research in few studies. One was to determine the effect of secukinumab compared with the saline group to see that our model of inducing asthma was good. And then we administered lipopolysaccharide to induce also acute lung injury. And we respected all the we respected the protocol which was already done in literature. What we added more, it was 1 dose of lipopolysaccharide, and the protocol was simple for almost less than 3 weeks, 18 days, with the 2 stages of sensibilization to ovalbumin, then inducing ovalbumin sensitivity, then administration of lipopolysaccharide. In the case of secukinumab administration, it was starting, here are the stars, in the day with the lipopolysaccharide administration. A second study which determined evaluating the effect of secukinumab associated with magnolol. In this study, we administered magnolol before, at the beginning of the sensibilization with ovalbumin. A third study evaluated the different doses of magnolol, of 50 and 100 milligrams per kilo, because we noticed that these are with effects on interleukin-17 axis. Another study evaluated 2 doses of honokiol, because honokiol and magnolol are relating with quite similar structures. And the fifth study evaluated the effect of metformin, which was administered, as we can see, in the same day, in the same moment when we administered the lipopolysaccharide. So in the moment in which we induced pulmonary lesions. And we used the equipment which were in the departments I told you whom we collaborated. And the results, our results were published in let's say journals who accept experimental work. Mainly the results were first of all, it was confirmation of the existence of oversensitization in exposed groups, as can be seen here compared with the control, without differences between experimental groups. We also evaluated cellularity in bulk, and as you see, the neutrophils are higher because it was administration also of lipopolysaccharide. There were changes in inflammatory cells. Here it's just microscopy evaluation. And as you can see, neutrophils are in the group with OVA and lipopolysaccharides. And also in groups with secukinumab and also dexamethasone. So in all groups with OVA and lipopolysaccharides. And here are effects on bulk cytokines and on the lung tissue homogenate. And here are comparative effects on different interleukins compared in bulk or in the tissue. In some are similar modifications, but in other are, let's say, quite a few differences, as you can see here for interleukin 6, or for here for interleukin 4, and for interleukin 13. What is interesting, in the interleukin 17, you see the secukinumab made different differences, different effects on the bulk cells and on the lung tissue. Here is also the effect on the weight, means that here at the moment 6 days, 0, 6 days, 14, 16, 18. As you can see from 14 when we started the lipopolysaccharide administration, the weight was done, means that it was a complication of what we induced on the bronchial asthma and the model we induced. And here are also histologic evaluation with modification, characteristic modification of inflammation and protective effect of secukinumab. I used only the secukinumab to show all the stages. Because other data regarding the association between secukinumab and magnolol are showed similar, quite similar effect of protective effect of association. Of course, not very strong, but good. And the effects of magnolol and honoquiol of different doses and of metformin were also published, but only partial. This is why I didn't show all the results here. But it's important to the conclusion that secukinumab has the ability to modulate the inflammatory cytokines response and to decrease the levels of interleukin 5 and 17. So it's a potential target. And the secukinumab also decreased the interleukin 6 level in BALF. So BALF is the bronchoalveolar liquid. Secukinumab and associated with magnolol both have inflammatory have inhibitory effect on interleukin 17. Magnolol treatment reduces neutrophil infiltration and promotes the transition of pro-inflammatory macrophages and has a role of in the tissue repair and resolution of inflammation. Also, magnolol and honokiol decrease the concentration of TNF-alpha and interleukin 6 and also on the axis of interleukin 17, these cytokines, and they have different effects. The honokiol increased also the level of interleukin 13. Metformin, they reduce the macrophage infiltration and neutrophil infiltration, and has also effect of reducing interleukin 17, interferon alpha, TNF alpha, and other interleukins. What I can say about these drugs is that they have potential, but what we noticed was only the influence of inflammatory cytokines, and the research should be continued to evaluate also the mechanism by which these drugs are acting on this model. Thank you very much for attention.
Thank you. Yeah, I have a few questions. So this antibody against IL-17 is a human antibody?
It was a human antibody. We found in a paper that in literature are controversies. In one paper, it was said that they are not acting on mice. In another paper, was said they are active on mice. So we just tried to see if it's, and we obtained results in our model.
And the mice are immunocompetent or immunodeficient?
Immunocompetent.
So perhaps there's a response against the antibody? Is that if it's a humanized antibody?
It's possible.
Have you looked at antibodies against that?
We couldn't do more than this because the financial support for you know, we had 3 theses, PhD theses to do this, and some of the reactives were you know, borrowed from others because it's difficult to have let's say a research and we didn't have a huge experimental project.
Then the other question is, so some of the cytokines you showed, like interferon gamma, IL-6, they may affect the vasculature as well. Have you looked at the vessels, the capillaries in the lung? Is there any change related to this inflammatory response?
We have some, yes, we have some histological tissue which should be analyzed further. We don't have yet the results because we didn't have all the reactives to finish the analysis. Yes, we just took the samples because having an experiment difficult like this and having such a huge team involved, you need to take everything which is possible and to analyze later when you have possibility.
And also, I think it's important to look over time because yes, neutrophils may be very important in the acute phase, but you may see, monocytes or lymphocytes playing a larger role as you go to day 18 or
Yes.
so. Perhaps I don't know if you have tissue samples at all those time points.
No, we have only 1 point samples, 18, the day 18. In literature, usually they took only at the end of the experiments. They didn't, to repeat the experiment and took samples of different moments will be very interesting because we can characterize the evolution, but we didn't have enough animals and we didn't have enough. It was just the final point.
Any questions from the? All right. Well, thank you very much.
Thank you.
We will continue with the study of microbiota. No. 1 second. 1 second. No. The clinical utility of accurate triplex quantitative PCR detection of nephropathogenic viruses in KTRs. Professor Ursu, please.
Hello. My special thanks to Professor Dankovic because without this kind of collaboration, this study could not be possible to be presented here today. I am happy to present our results for the moment because this is one pilot study for the moment. We are going to continue as soon as possible. I will start to present to you some data which are offered by the latest information from Global Atlas of Kidney Health, which was published in the Lancet this year. And it's very interesting that it is presented the prevalence of chronic kidney disease, and the conclusion is that the highest prevalence is in the Eastern European countries and in the Central European countries, and it's the average it's around 9, and the conclusion is that the prevalence is increasing according with the high income in each country. The same conclusion it's seen in this kind of this map, which is showing to us that the prevalence of chronic kidney disease is associated with the number of the doctors in the countries and according with the finance which are given to this disease to be analyzed. It is also known that dialysis, which is more cheaper than kidney transplant recipient, can be used more efficiently for the patient follow-up with kidney transplantation, as this significantly improves the patient quality of life in both terms of physical and mental health. We are going to present some data about some viruses. We start about the first of them, which is BK. It's a polyomavirus. It's a DNA virus. And it is known from now that it's associated in 1%, around 10%. There are some guidelines regarding this virus, which is telling to us that it's suitable to follow up the patient for 9 months after 1 year after transplant, and then 3 years after 3 months after the 2 years from the transplant. Also, it's very important viremia for this virus, and according with the number of viral copies should be optimized the therapy for associated nephropathy induced by this polyomavirus association. The second virus that we want to mention today is cytomegalovirus, which is one herpes virus from herpes viridae family. It is known the percentage which is associated with this nephropathy, which is with this chronic kidney disease. It's between 40 and 80%. There is no efficient program to follow up this category of patients for the moment. But it is known that if it's appearing this infection the first year after infection, there is one risk for complication for this category of patients with kidney transplant recipient. Less data are known for Epstein-Barr, which is also one herpes virus from herpes viridae family. It is not known exactly the prevalence for this virus because the data are not specific and not all the people are testing for this virus in kidney transplant recipient. But also it is known that if it's present in the first year after the transplant can appear complication, and there are indication therapy with classical antivirus like acyclovir, valacyclovir, or ganciclovir. In our study, we intended to perform one comprehensive analysis of all of these 3 viruses in KTers patients, and we want to assess the frequency, and we'll continue further with some other study. We start with one number of patients of 164. These patients were all of them selected from Parhon Hospital here in Iași. We excluded the patients which had the age before 18. We also excluded the pregnant women and the one which were unable to give the consent for participating in the studies. Finally, we had 157 patients, which were analyzed by district classical method for qPCR, meaning we purified the DNA from the blood from this patient. We then amplified with the system strategy MX 3005P. And lately, we analyzed the data according with the clinical results from each patient in part. I will present to you a very classical, basic experiment of qPCR, meaning this is the plate for real-time PCR. First, it's very important for us, the NTC, negative template control, because in this one, we want to prove that we work correctly and we have no contamination in our experiments. Then we have all the patients from the first setup. We work with 30. This is the optimal number of patients in our experiments. And if we want to quantify, we are using standards from 1 to 6 in different concentration, and using this kind of standards, we are able then to quantify the amount of DNA in each kind of patient sample. Our principle was Tuckman principle, which is a very sensitive assay, because if we compare Tuckman with CyberGreen, for example, in Tuckman we have no risk for false positive results. Like any kind of qPCR experiments, we have one classical type of thermal profile, and it's very important to set up precisely this thermal profile to have optimal results. Of course, we have a lot of controls, negative controls, endogenous control. Endogenous control was helping us to prove to ourselves that our DNA was valid from biological point of view. And we were able to detect each of these 3 viruses by different signals. For example, we detected EBV using FAM channel, CMV using VIC, and BKV using ROX channel. After interpretation, after qPCR experiment, we were able to interpret the results. And how was possible this one? First, to check the negative controls. If these were negative, we can control our experiment to validate from this point of view. Then we want to check the positive control, which is very important. If the positive control is not present, means that something is not working correctly with our experiment. And then for the virus, if anything was passing this threshold, means that this sample is positive for that target that we are searching for. We are able, using the software of the experiments, to see which are the results very fast. It's a very fast experiment. First, after finishing the experiment, we are checking the NTC, and we are seeing that we have no CT for anything that we search in our reaction. So no positive control, no EBV, no CMV, no CMV. Then we checked the standards, which looks okay from our point of view, yeah, because we want to have increased CT values to be able to perform the standard curve. And then it's coming the fun moment when we are trying to see which patients having which virus, because we are trying to see in which kind of sample we are having one positive control. First, to check the endogenous control, yeah, the one which was read with Cy5, and after seeing that the internal control was okay, we can read our patient results after. We can see that in patient number 1 in this setup, there is no virus detected, but in patient number 12, for example, we have one virus with CT number 38. And the same software for our platform is able to give to us one text report, and we are seeing even more better which are the results for each of the patient tested, which of the sample which we tested before. Very important for us is the standard curve in this experiment, because using this standard curve, we can quantify the DNA amount in the initial sample. And what is new for this experiment is that we were able to optimize the qualitative assay in one quantitative one, meaning that the kit was offering the possibility only to simply detect the virus presence. We are having some experience with PCR in some other regions using backup polyomavirus, and we perform standard curve for each of these 3 viruses, and this kind of standard curves is helping us to quantify the DNA from the initial amount. These are the parameters for one correct standard curve for all the qPCR experiments, and as we are okay, as we are good according with this one, we can go further with the with analyzing the results. From our study lot, we had around 40% women, and here I presented all the positive sample for Epstein-Barr. So we had 5 sample positive for EBV, 9 for cytomegalovirus, and 11 for backup polyomavirus. We added the CT value in comparison with initial template quantity of DNA to see the comparison between the CT value and the amount of DNA. Then I wanted to see more from a statistical point of view, because as you can see, we have 10 to the power 2 for FAM, we have 10 to the power 2 and 3 for ROX, but for CMV, we have the highest amount of DNA, 10 to the power 4. We try to introduce the data in SPSS, and we categorize the value, and we get some results like this with this table. They are just results for the moment. We are going to continue to optimize our statistical interpretation. The idea here is that the highest amount of DNA was present for cytomegalovirus, and the highest prevalence was for backup polyomavirus. For the positive patients with these viruses, we clinical data for us, meaning we try to see which kind of donor is having our patient, which kind of therapy is receiving, if it's receiving tacrolimus or prednisone or some antivirus like valacyclovir. And also it's important for us the serum urea and ureas. All of these data are just descriptive presented now. In the close future, we want to extend our SPSS database to introduce all the data and to compare which might be the risk factors for our patient analyzed. We realized our testing. We have some experience for the moment, but still we are asking, are we okay with what we've done? Are we safe with what we analyzed for the moment? Because like a laboratory person, I'm very aware about the sensitivity and specificity of the method, because I need to be aware and to be reliable of what I'm saying to my patient. And that's why I was trying to compare our results with what is written in the literature, in the special paper. And I performed one special analysis of all the data published in the last 5 years for these 3 viruses, which were tested in 8 years patients with the same, real-time PCR. We perform basic kind of searching in PubMed using some filters, and we identified 2 studies with EBV, 12 with cytomegalovirus, and 13 with backup polyomavirus. We read all the full text of this paper. We analyzed all of them regarding the number of patients, regarding the type of assay used, the results, and why was important this assay for those authors which published these results. After analyzing all of this, we seen that all of these studies analyzed many kind of samples, starting from blood, from plasma, serum, urine, and tissue fragments. So different kind of sample, not only blood like we did for the moment. And like a conclusion for the moment, we have seen that the authors have used many types of PCR, because it's not only single one, can be many variants of PCR, real-time PCR. Some of them were followed with sequencing analysis, which is giving to us more information, more detailed information. Some other results, some other studies showed to us the phenotype of some cell then some other quantify the expression of the cell, of some genes, and all of this to help to identify factors which are influencing the activating of this latent infection. Some other studies have tried to correlate the risk of these viruses with the appearance of cancer in the kidney. In conclusion, the prevalence of these three viruses was varying according with the type of pathological product, with the type of variant of real-time PCR assay used, and according with the length of the period since the transplant was performed. Also, the conclusion is that real-time PCR can be considered one robust, cost-effective method, mainly in the first year after transplant. And still, we need to use recommendation from the guidelines to avoid as many as possible complications in this kind of special kind of pathology. Our study for our results for the moment was published in this journal. And for the future, because we want to continue our research in the close future, we want to look to our data and to compare with the guideline to see if we work correctly or not. And I searched guideline for each of the virus. I found this guideline released by WHO, which was from 2015. And I was happy to see that even for this virus, WHO was released a prototype for BK DNA virus for testing. And since then, this kind of prototype is used for all the nucleic acid testing for evaluation of this virus presence. Also, there is one guideline which is trying to correlate the risk for appearance of cancer for BK polyomavirus. And I want to show to you this guideline, which I was also mentioning in the beginning, the guideline from the American Society, which was telling to us that it's good to follow up the patient monthly in the first year after transplant and then 3 months after the transplant. It's important that they show to us how much will be the viral load for each kind of the sample, urine, plasma, and biopsy. But I was very interesting to read about this research issue, meaning that the authors, even they are having so many data and so many important solutions, they are still requiring the need for standardization of the methods. They need to have one established threshold of viral load, because we need a value of this amount of DNA to be able to detect the patient at risk for developing further nephropathy. The same need for defining the threshold was seen in this kind of guideline, which was released in this paper, Transplantation Review. And after presenting CMV involving in many transplant, and they are having a very nice recommendation for using antiviral therapy, they are still recognize the need for establishing of one threshold, viral threshold, for starting therapy for asymptomatic patient. For me, like a virologist, it's very important, this threshold, because I know what it means from my previous experience with some other viruses. For EBV, there are less data published. This is one of the latest of them. It is one study which identified, as you can see, only 8 patients with EBV. The authors published this study in a very important journal, and still they need also to have some data regarding initiating the therapy with mTOR inhibitors, for example, to optimize the evolution of this kind of patient. We need this data because we want to correlate all of this information in a team, because nothing can be done like a single person, it's a teamwork. So we need to correlate this prevalence of viruses with different biomarkers from clinical, paraclinical. We want to avoid as many as possible deleterious effect. And we hope that in a close future, by working in a team, again, we need to be a very efficient team and to collaborate. We want to establish one monitoring algorithm and one personalized therapeutic approach. Thank you very much.
Thank you. Again, this is not exactly my area, but as far as I can understand, did you have a group that didn't have transplant rejection to see whether there would be because causality is very difficult to establish anyway in human studies, but how do you know that this virus is playing a role?
That's a good point. It's a very good point, this one. So from 150 patients, we have only those small numbers of patients positive. This is just a detection of frequency.
Right.
If we want to prove that they are having any effect in evolution, we need to follow up closely this patient. Yeah?
And so the infection is in the donor or recipient? What is the hypothesis that this is playing a role in rejection?
Well, we tested only now the patient which received the kidney. Yeah?
Right.
So I don't know nothing for the moment about the donor, but maybe we can try to ask, but I hope they are negative. I hope for the good of the patient.
And for CMV, at least in cancer patients, the prevalence is very high. I think it's like 70, 80%.
Yes, yeah. It's
So what is the prevalence in the Romanian population overall? Is that
it's also high, I presume, but I don't have any data for the moment. But the general, it's high because it's ubiquitous virus, so it's for sure high.
I see. Okay. Yes, Professor Kovic, please.
As you've shown, and I'm going to answer your excellent point as well. In transplantation, whatever transplantation we have, there is always a struggle between too much immunosuppression and too low immunosuppression, and you've got rejection. Now, if you have too much immunosuppression, then all those kind of viruses are going to pop up. Some are probably neutral, like the Epstein-Barr virus. Some are, let's say, so-and-so, like the CMV, probably the gastrointestinal issues are more, let's say, problematic than the renal issues. The BKV is a direct nephropathogenic virus. We know that. And there are plenty of studies showing that once you have a nephropathy with the BK virus, then you are probably going to lose the kidney if you don't change something in the treatment. Having said that, now it's the important part of this paper, because we don't know how to diagnose and what is actually the infection. Is it plasma serum? Is it whole blood volume? Is it urine? What are the levels? By which method? Is it cells infected? Is it through which kind of PCR? So I think this is a truly important paper from this point of view, and even there is no consensus in the literature. We know that once that, then the second point is it's not from the donor. It's probably we have the virus, some of us, some we are going to catch it. So how often do we measure this kind? How often do we measure in the first year when we have a higher immunosuppression? How often do we measure it further down? And I think this is an important point. And my question here is to you: do you think that we can have now like a standard and also a lab which would be also not only in terms of research, but in terms of maybe doing let's say for profit for the university, because there are not very many labs accredited and doing a good job. That's a question. And the other important point, which I was going to raise for you, is we have a funny virus now, which is called the TORC-10 TTV, and it's probably the best marker for immunocompetence and for perfect immunosuppression. So if you have too much TTV, then you don't have immunosuppression, and the other way around. And it's actually used in cancer research as well. Can we do that? I'm not sure if we can do that, but it's an entire European project on that, and I was keen to see more. So those were the 2 points.
Thank you, Professor Kovic. Regarding TT virus, I don't have any experience for the moment, but I can try to search what is written in the papers. And for sure, if I'm trying to work with a company, I can try to find some kit to detect this kind of virus and to test our sample. Thank you. The first question regarding standardization, it's a huge process. Yeah, I can tell you from my previous experience with HPV. In HPV, it was the same, a lot of qPCR assay, which were trying to detect HPV. But some people from Netherlands, which were the top in the field, they wrote on guideline and they say, the one which want to send this kit need to accomplish this kind of data regarding sensitivity, specificity, predictive positive value, negative one. And if they were in the beginning around 40 kits for HPV testing, now they are around 10 because they proved by clinical validation that they were able to reach that sensitivity, specificity. And I think this should be done in a higher level. Of course, it can be a small part, but we need to work in a higher level because it's a very important thing. It cannot be done like this. Just we can try to start, but means a lot of collaboration and people involved. It's an important thing to be established worldwide, but we need standardization. I agree with you. We need it.
Thank you very much. In the interest of time, we'll stop the discussion here. Thank you very much. And we have a slight change in the program. We will hear now from Professor Kovic. His talk will be about entitled Hemodiafiltrarea.
Thank you. I thought that we are going to shift gears a little bit from too much lab work, let's say, and I'm a fan, as you've seen, of fundamental research. Let's move a little bit to clinical research. This is a cartoon showing, in fact, that in the last 50 years, as you can see, our life changed fundamentally. There are guys who are saying that my phone, my latest Model of iPhone, is actually better than the computers which were used by the NASA for the moon landing. This is why they don't believe in moon landing. There are so many others changes. But in fact, if we look at the dialysis machines and the basis of dialysis machines, in fact, nothing changed during 50 years. And this is absolutely incredible discontinuation and dissociations between a simple, let's say, technique and advances in technology. And in fact, we are both lucky and unfortunate, because if you look here, there is no much difference between hemodialysis and PD. That's not the point. The point is that at 5 years, 50% of this population is going to die, probably of cardiovascular complications and some other complications. And this is a death rate which is higher than any other pathology, current pathology, metastatic cancer, and so on. And to further support this, you have here the general population, and you have the expected survival for dialysis and for transplantation. And of course, transplantation is better. But look at the difference between dialysis and the general population. So, in fact, we are still doing very badly. And I'm not going to, let's say, to discourage you and to make you leave discussing about dialysis. This is a very simple cartoon showing that basically what's going on in the last 50 years. It's this process in which a lot of toxins, small molecular toxins, larger ones, are actually cleaned through a kind of membrane, and according to the physical properties of this membrane, you are going to have a diffusive process, and then you are going to have removal of the uremic toxins, and life is possible with this dreaded complication. Whereas, for example, if we talk about other end organ failures, liver disease or heart disease, life is not possible because there is no support for those end organ damage. Now, this is convection. In convection, we have a negative pressure here, and we can take as much fluid as we like. We can take 1 liter out, we can take 25 liters out from the body, and with that we can take both small molecules and we can take larger molecules. So we can take out the entire spectrum of toxic molecules which are present in the body. So we think that we are going to have an improvement of all sorts of solutes. We think that we are going to have a better correction of the uremic milieu with a stable dialysis and less cardiovascular damage, with lower cardiovascular morbidity and mortality. Now, if this is true, we have to see that in a sort of continuum between studies, randomized controlled trials, meta-analysis, and real-life registry data. And 10 years ago, when Ionuț here was working with the Cochrane team, we actually were the first looking at the entire spectrum of convective therapies in smaller studies and larger studies. And as you can see from this meta-analysis, in fact, the conclusion was rather, let's say, discouraging. No difference between standard dialysis and more higher quality dialysis, convective measures, and so on. But this meta-analysis was criticized, as usually meta-analyses are criticized, because they told us that we are putting together pears and apples. And when you have pears and apples together, then you are going to have wrong conclusions. And there were many issues with, let's say, with this kind of conclusions from the meta-analysis. So then a group of researchers looked at only the randomized controlled trials, the only randomized controlled trials in the field. And as you can see, there is only one which pops up. This is a Spanish study. And I'm not going to describe this study because it had a lot of issues, particularly a lot of bias in it. But in any case, as you can see, all the results were between a powerful effect on mortality and no effect on mortality. So this was then analyzed by a lot of wise men, and they draw the sensible conclusion that, in fact, if you have a higher convective mechanism, as I've showed you, you can, if you take more than 1 liter, if you take 20 liters, 30 liters from somebody, then you are going to have a higher capacity of cleaning the body. And of course, then you are going to show an improvement in survival. Whereas if you have lower clearance, like in some of those randomized controlled trials which were negative, then you are not going to show any survival. So back to the future, back to the initial Cochrane meta-analysis. In fact, we showed that even if we put apples and pears in the same basket, there is a sort of indication that convective measures are helpful for cardiovascular mortality and morbidity. And I'm not going to get into detail at this point of the presentation. So then let's move to only randomized controlled trials. This is an interesting person which claims, we've heard a lot of discussions and presentations about claims these days. He claims that he obtained this rather perfect body only by eating only apples during 2 months' time. So you can try that. But in any case, this brings the idea of looking at only the randomized controlled trial, but even in the perfect way. So what the authors did here in this best publication from the European journal NDT, they contacted all the individual authors of the randomized controlled trial, and they've obtained the individual data of 3 patients. So it's not a proper meta-analysis, it's a study combining all the individual data, and this actually was positive. So in fact, now there is a suggestion that even with the meta-analysis, we have a positive, somehow positive result. And with that in mind, in fact, also our group approached the larger provider of dialysis in Romania, with this simple idea: let's have the registry data. And I don't know if you know, but in contrast with any other, let's say, specialty, even oncology, unfortunately, in Romania, the nephrology has an absolutely perfect registry, meaning that any patient who enters dialysis is actually followed from the very beginning by law up to the end with all the parameters. So that means that we have full electronic records for a long period of time, which is very close to, let's say, a prospective study, although this is a retrospective analysis. And this was highly positive, both in the prevalent and, very interestingly, in the incident patients, because at some point we said we are going to look only at the newcomers in the registry, and as you can see, the difference is actually even larger. But still, with that in mind, people were not believing. So we've heard yesterday from Professor Apetrei, then even if you have evidence sometime, you don't believe in that evidence. And we've seen that in our society recently. If something or in something, evidence doesn't matter. So with that in mind, not the industry, because industry is going to be biased always, but the European Society proposed to the EU in the Horizon program, after a group of investigators actually planned a larger study. They had this multi-European CONVINCE trial. And basically, this is a large study which compared convection with classical dialysis. And they have primary outcomes and a lot of secondary outcomes, some to be reported. A very simple design, similar to the cardiovascular large trials. You have the intervention, and by now we know that the intervention should be a large convective volume. And then we have the best of dialysis as we know it today, and with very simple outcomes. This was, as I've told you, a proper study, because it had all kind of centers, large centers, small centers, centers from Eastern Europe, centers from Western Europe. As this is London, Guy's Hospital, and Oxford, Heidelberg as well, Munich somewhere, Paris, industry centers and non-profit centers. So there was a very good representation of what's going on in Europe. But most importantly, in fact, let me go back. The largest two centers in the entire study were from Iași, and all my colleagues were leading those patients in the study. So Iași had by far almost like 10%, if I remember correctly, of the patients in the study. So this is the New England Journal of Medicine main result. The two curves are diverging immediately. They continue to diverge, and this is in favor of the convection volume. But then we had some interesting findings. A first finding, and this is the table with the Cox results, we didn't see any beneficial effect on cardiovascular death, as it was shown before. We saw some results in non-cardiovascular death, and interesting enough, and I would love to hear your input on that, because there were a lot of comments related to COVID, to inflammatory cytokines, and so on and so forth. There was an improvement in the non-cardiovascular infectious-related death in the convective group. Also, the group showed a very important feature, that this is feasible everywhere in Europe. This was the convective volume throughout the study, and that was a high convective volume, which was supposed that it is very difficult to obtain in some, let's say, large center, non-university center, and so on. So this was obtained everywhere. And the study opened very important perspectives because there was no reason for any safety. There was a considerable beneficial effect on all-cause mortality, but we had some issues with the specific mortality. So some outstanding question. First of all, there is any particular patient subgroup, diabetics, older patients, more cardiovascularly compromised patients, which will benefit from convection? Is there any difference in terms of cause-specific mortality, infectious-related, which infections, vascular damage, MACE, so on? And then what is the relation between convection and the dose of convection? Let's go back to the Lancet meta-analysis, which was published now at the same time. And in this Lancet meta-analysis, they again did the same thing as before, meaning that they had the individual data of all the trials plus the convince, and they showed that incredibly for a method which is for a very sick patient, is only sufficient to treat 26 patients in order to avoid a death. And this is in line with the best cardiovascular research current, because you know, for example, the SGLT2 inhibitors, they show the same improvement, the same numbers needed to treat of around 26. Furthermore, moreover, they actually showed numbers needed to treat of 48 for the cardiovascular mortality, meaning that you have to treat 50 patients to avoid a cardiovascular death. And there was no difference in the subgroups, meaning that, in fact, we cannot pinpoint a particular group, diabetes, older patients, or some other subgroups. And as you can see, there was almost a linear relationship between the degree of convection. There were some patients going up to 30 liters and the survival. So, and you have the break even about here, which is the 23. But that means that, in fact, that for particular patients, if you go even higher, then you are going to have an even greater benefit of survival. And I think this is an important point. Now, dialysis patients, I'm sure that you've all seen some dialysis patients. We actually fear them because they have cardiovascular complications, they have hematological complications, they have digestive complications. So it's not only a question to survive in dialysis, it's a question to survive with a good quality of life. And let me show you that, in fact, first of all, HDF convective therapy were associated with a reduced rate of hospitalization. And I think this is absolutely crucial for a method which treats an end organ damage. And then we looked, the same group, we looked, and this was published in another major journal, the patient-related outcome, which is very on top now. So now, with any method, we have to look at first of all, at the survival and then at the quality of life. Similarly, in cardiac failure patients, it's not only a question of surviving cardiac heart failure, it's a question of surviving with a good quality of life. And those are graphs which are really very important because, as you can see, between the two methods, there is an improvement in fatigue, in cognitive function. In fact, there is less destruction of the cognitive function. There is an improvement in the sleep dysfunction, in depression, and I think that's an important because we are talking about a chronic disease. So, in fact, all the patient-related outcome related to the quality of life were better. Now, and in the last part, I'm going to show you some of the mechanisms, and I think those are interesting as well for those of you which are doing fundamental research. And this is an incredibly small study, but an incredibly good study, because what they did is they looked at, for example, at the cardiovascular related tissue injury by looking at the endothelial vesicles and myocardial cells derived vesicles. And it's a sort of, let's say, close to apoptotic bodies. So what happens when a cell dies? Some of these vesicles are shed out before the cell is dying. So they can actually look at the damage at the level of the cardiovascular tissue, and immediately you can see that the very high volumes of convection are related to a better, let's say, endothelial function and myocardial function at the structural intimal level. There is a reduced level of larger molecules, such as beta-2 microglobulin, increased efficiency of dialysis, and beta-2 microglobulin is important for neurological damage, for all sorts of damages which are not immediately related to uremic toxins. It reduced inflammation and oxidative stress, so it improved all sorts of measures of endothelial function, starting from basic measures of endothelial functions, fundamental research in like looking at the capillaries and the reactivity of the capillaries. And it also improved the resistance to erythropoietin, meaning that there is less anemia and better control of anemia without iron and without erythropoietin. There are a lot of questions which are still not unanswered now. And in fact, this is from the UDL group. Also in the working group are many of us from the Parhon Hospital. And actually, we were objective enough to show the good results, but also to show the questions which have to be answered. And there is another major study going on now in UK, and probably if that study is going to be positive, we predict that a lot of renal replacement therapy, both in Europe and in the US, is going to be changed. In conclusion, this was truly a milestone in dialysis research. It provides for the very first time evidence that we can change the survival and quality of life and some other prompts in this category of very difficult to treat patients. Results did not differ across patients and treatment characteristics. And this is the team behind. You all know Mihai, Ionuț, Luana, Mugurel, Simona. Dimi is not dead, but is not with us now, but he was part of the team. And also, yesterday I resonated a lot with the fact that one team is really a good team when it produces, let's say, research with the help and for the youngsters. This is a part of our youngsters team, and there are even more than that which were involved in these studies. And I always like to be provocative, so I'm going to leave you with this quotation from Lancet. And they said in Lancet, many doctors, so nephrology is not for the normal doctors, it is for the exceptionally skilled specialist physicians. And many doctors view nephrology as a remarkable kind of intensive care. But in fact, the patient presents in acute crisis close to death. And then there is an immediate transfer to the renal team. And the renal team actually is sometimes sad, but sometimes really absolutely delighted to save the life of those patients. And thank you very much on behalf of the team which is in this auditorium. Thank you very much.
Thank you very much and congratulations. I'm not sure how qualified I am to ask you questions, but let me start by asking you, why is this controversial? I mean, is the method more expensive, or is there a safety concern, or why is this even such a...
That's a very good question from a, let's say, a neophyte. First of all, there was a discussion if you can obtain the 23 liters convection volume. You need a good access, a good fistula, or a very well-placed catheter. If you don't have this kind of volume, you've seen some of the studies were negative. Also, the second point is that we still don't understand why this huge positive result was obtained. Before convinced, we were almost convinced, if I may say so, that it has to be related to cardiovascular improvement during dialysis, after dialysis, parameters of the heart, parameters of the vessels, perfusion of the brain, perfusion of the gut, less inflammation from the gut, and we haven't seen that. We have only the signal related to inflammation and oxidative stress, but we haven't. So now we are puzzled because we have a tremendously huge result, but we can't explain it yet. So this is the second point.
Yeah, and I don't know if I noticed correctly, but from the Lancet paper, it looks like transplant patients actually have a higher hazard ratio than one, and all the others seem to benefit. So is that perhaps one of the hints that what might be happening?
Transplantation is for sure better than dialysis, but there were some recent data analysis of large registry. It depends of when you put the cutoff. If you put the cutoff of 5 or 10 years, then transplantation is by far. But if you put the cutoff a little bit further down, like 10 years, then the positive impact of transplantation together with the comorbidities which are brought by transplantation, a lot of cancers, infections and so on, are, let's say, dampened a little bit. So this is why now people are moving also towards new approaches to transplantation, as you are aware, including looking at immunosuppression regimens, not to have so much inflammation and viruses, because we are not happy with the results of transplantation, irrespective of which kind of organ we have.
Questions for Professor Kovic from the audience? No, everybody's hungry.
Thank you.
Okay, thank you very much.
So in the interest of time, I will ask the next presenter. Would you accept, I mean, if that's okay, do you want to have lunch first? He's presented now. Okay, so you're presenting now. And after that, we're going to have lunch and continue.
Okay, so hello everyone. I'm very glad to be here and for the opportunity to present some data from our department about the liver fibrosis in northeastern of Romania under the coordination of Professor Dr. Anca Trifan and Professor Dr. Carol Stanciu. Firstly, I will describe some data for the literature. Nowadays, chronic liver disease is a major cause of morbidity and mortality, with approximately 1.75 million deaths per year, with a prevalence with an upward trend from Western to Eastern Europe. In Romania, the prevalence is more than 1,100 cases for 100,000 people, and the general population, we see that the prevalence of significant to advanced fibrosis is 12.6%, and the prevalence of liver cirrhosis is 5.4%. Also, in the young adult population, 1 in 40 of the individuals had liver fibrosis. About the mortality, the chronic liver disease nowadays produce about 3.5 deaths globally, and the main causes are the non-alcoholic fatty liver disease, the alcohol consumption, the chronic viral hepatitis. And the mortality in our country is more than 36 cases per 100,000 people. And a study from USA 2 years ago show us that the chronic liver disease produce high unemployment rate, which is about 34.5, more than 6 times than in general population, and produce high care expenses. A patient with chronic liver disease costs around to $20,000 per year. Nowadays, exists a new nomenclature from non-alcoholic liver disease, which is metabolic-associated steatotic liver disease, which is no longer viewed solely as a hepatic manifestation of the metabolic syndrome. The type 2 diabetes and obesity have the strongest impact of the natural history of MAS-LD, and the prevalence globally is around 38%. Which also is the main indication of liver transplantation in USA and the second one in Europe. About the diagnostic of liver fibrosis, the liver biopsy remains the gold standard and can distinguish between non-alcoholic steatohepatitis from simple steatosis, but have several shortcomings like poor patient acceptance, high cost sampling errors, and intra and inter-observer variability in histopathological interpretation. Also, when we can obtain a liver biopsy in patients with non-alcoholic fatty liver disease or MAS-LD, in patients which have an increased risk of having steatohepatitis and advanced fibrosis, and other non-invasive methods don't describe very well this kind of things. And the liver biopsy should be considered in patients with non-alcoholic fatty liver disease when we suspect another etiology, which cannot be excluded without liver biopsy, such autoimmune hepatitis or primary biliary cholangitis. So the European guidelines presents us a list of non-invasive tests, such as serological one, APRI, FIB4 or NFSS score, and the imagistic ones like transient elastography, share wave elastography, or MRI. And also the best way to meet this challenge is to use the sequential use of non-invasive tests. In the primary health care, they must use the FIB4 score, and if it's more than 1.3, then to refer to the hepatologist center, where we can use a non-invasive method like transient elastography. Also, the prevalence of liver fibrosis and cirrhosis among general population is variously in the studies from Europe. The study from Poinar show a prevalence of cirrhosis of 0.3%. And our study, which was published last year in Hepatology Communication in our team from the Institute of Gastroenterology and Hepatology Institute, we enrolled in this study a total of 1,027 apparently healthy subjects, mainly females with a mean age of 55 years. 12.6% of the participants were found to have significant to advanced fibrosis, and 5.4% had liver cirrhosis. Among these patients with clinical significant liver fibrosis, 26% had a history of heavy alcohol intake, and 22.3% were tested positive for chronic hepatitis B or chronic hepatitis C infection. And the remaining of approximately half of the participants were diagnosed with non-alcoholic fatty liver disease or MAS-LD nowadays. So we found the eligible population of 1,088 participants. We excluded the subjects with declined informed consent, 29, and we excluded subjects with unreliable measurements of transient elastography. So in the final cohort, we found 1,027 participants, apparently healthy, with a high BMI of 28.16 kilogram per metric cube, and also approximately 30% of them had obesity. So, using the appropriate algorithm of EASL guidelines about using FIB4 in the first part, and after that using transient elastography, we found that approximately 45% of our subjects were found with a FIB4 less than 1.3, and these patients were with clinically significant liver fibrosis, advanced fibrosis or cirrhosis. This means that the transit elastography is a better option for patients to describe their liver fibrosis level. Also, in this study, we observed that for patients with alcoholic-related liver disease, the mean liver stiffness measurements were around 14 kilopascals, and also in the group of patients with chronic viral hepatitis, we found that around the kilopascals levels were around 12.23. Also, we make a repartition of each group category, and we found that 2.2% of young adults have liver cirrhosis. In the group of 41 to 60 years, 4% of people had liver cirrhosis, and in the older groups from 61 to 74, we found the prevalence of liver cirrhosis of 8.8%, and in the elderly group, from more than 75 years old, we found a prevalence of 9.6%. This happens because the older patients presented with alcoholic liver disease or chronic viral hepatitis, which has not been treated yet. I also want to show you some results of a study about medical students, which happened 2 years ago. We enrolled 426 medical students, and we found that in this group, the liver steatosis is present approximately at 1 out of 5 of our students. Also, we found that the prevalence of liver fibrosis is more higher in the group of hepatic steatosis. About 11% of patients had significant liver fibrosis. These results show us that the prevalence of steatosis and significant fibrosis is low around healthy medical students, but high BMI and waist circumference values are associated risk factor for liver steatosis as well as of liver fibrosis. In the list, I want to present some data about about vulnerable patient, which where we describe the liver fibrosis and the steatosis. In this group, we enrolled 560 individuals, and with a mean age of 48 years. They had important risk factors such as received blood transfusion in the past, 7.7% of them. The rate of type 2 diabetes was around 20.4%, and also 28.4% of patients reported consuming alcohol in the past. Also, we tested the patients for chronic viral hepatitis. We found that around 7% of them had chronic hepatitis B or chronic hepatitis C, and also around 60% of the patients had obesity or were overweight. So the final data shows us that about 20% of the patients have at least advanced fibrosis, 11.6 had F3 of fibrosis, and 8.2 had liver cirrhosis in this vulnerable group. And more than that, 78% of the patients had liver cirrhosis. Also, we show that there are important correlation between liver stiffness measurement and excessive alcohol intake, the presence of chronic viral hepatitis, the presence of type 2 diabetes, or on higher BMI levels. So in the conclusion, I want to say that in general population studied, at least significant liver fibrosis was observed in 1 out of 5 of the patients enrolled, and liver cirrhosis has an important impact in terms of mortality and morbidity, affecting 5.4% of the patients included in our study. Also, about half of the participants with clinically significant liver fibrosis were diagnosed with non-alcoholic fatty liver disease. Therefore, the improvement of the metabolic factors such as HDL cholesterol, fasting blood sugar, abdominal circumference determines the improvement of liver fibrosis and steatosis also. The assessment of advanced fibrosis using transient elastography in a vulnerable population indicates a higher frequency of advanced fibrosis and cirrhosis, around 20%. And approximately 1 out of 5 of our students had liver steatosis now, but with low levels of fibrosis, around 3.1%. Thank you for your attention.
Thank you very much. These are very worrying numbers. So is there any action that you're planning, for example, at government level to prevent this? Because these are very high numbers, especially for medical students. I'm shocked to see 20% steatosis. I mean, there may not be fibrosis because it's probably early stages, but still the numbers are very high. So what is the consequence of these studies?
The most important thing is that nowadays we found that the patients have important BMI levels that are overweight, had obesity, had high levels of triglycerides, so have some components of metabolic syndrome. So I think the first step is to establish them that the most important role is the dietetic regimens and to do some aerobic exercise, to implement healthy lifestyles in their lives, because otherwise the numbers will grow up, I think.
The other thing is, so a lot of what you've done is imaging, but have you also done any soluble, for example, blood test, or try to develop something complementary to the imaging techniques for these patients?
For the there are the serological scores like FIB4 or APRI or NFS score for the liver fibrosis. And the first step is for the primary healthcare to use one of these score. And when, like I show you, when is more than 1.3 for on FIB4, the patient must be referred to us to identify exactly if they are the risk, they present a risk for advanced liver fibrosis, or will monitorize him.
And did you find any incidental hepatocellular carcinoma, for example? You had a lot of, higher than 65, let's say, or even some with advanced cirrhosis.
Yeah, we exclude in that study the patients with liver decompensation, like clinically, or we saw also them echographically for the presence of ascites, and we exclude them. And from the remaining patients with liver cirrhosis, no one was found with, in the first view with hepatocarcinoma.
Any questions? No? If not, thank you very much.
Thank you too.
Let's give a hand to all the presenters. And bon appetit.
And see you back here at 1:35 at most. Thank you.